I come from hepatitis C from a different perspective in that I'm a doctor that has treated drug users for about 20 years now. And how do I move this forward? Oh, there we go. And we're located in Oakland, California, which is across the bay from San Francisco. And we have a small nonprofit organization. And I also want to talk to you about our syringe exchange work there and north, about 150 kilometers in wine country. I've spent the last day and a half talking about the crazy political situation in the United States, and we could have parallel discussions about the crazy medical situation in the United States. And this is of no surprise to any of you, I'm sure. We are the richest country in the world, and we have the highest per capita healthcare spending, but unfortunately we have a very fragmented healthcare system. There are deep disparities, there's neglect for the underserved and marginalized populations, and I know we have a plan to eradicate hepatitis C, but in reality, right now, we have no coordinated approach toward hepatitis C prevention, treatment, or eradication. In the US, drug use, unfortunately, is highly stigmatized, and unfortunately, it's probably most damaging in the medical population. A lot of doctors consider drug use to be moral deficiency rather than a medical illness. And in addition, in the United States, in many states, there is absolutely no access to hepatitis C treatment in people who use drugs, which kind of makes it hard to shut down the epidemic. These are the kind of places where I work, and I know these look like garbage dumps, but in our society where I live, this is where people make their homes. In the top two pictures, this is right near my clinic in Oakland, California. The sidewalks are now covered with tents and garbage, and this is where people live and stay, and hygiene is terrible. There's high rates of alcoholism and drug use. You can see the two encampments in the lower pictures. These are, despite the greenery, these are similar encampments with high rates of drug use. This is far north in wine country. These are near, both of them are near locations where we do needle exchange, Hep C treatment. We've heard a lot about the data in hepatitis C treatment, and we specifically heard about the absence of data in certain populations, and I would agree in children, they're almost an unseen group of people. There is a large group of people that we have good data on. They're on our radar screens for hepatitis C. And in my world, there are a lot of people who move in and out of our radar with hepatitis C data. They're drug users, they live in those encampments, they live out on the streets, but they only rise to the level of data when they're hospitalized or incarcerated or something like that. Otherwise, they live here, below our radar screen. They are out on the streets, a lot of them are young drug users. We aren't aware of who they are, what they're doing, because they don't rise to the level of data. We might have some surveillance data on them, but they don't come to clinics. They have never been in care. They certainly have never been in studies of hepatitis C care and treatment. And so we know virtually nothing about them. And as I would encourage you, as you look in other areas toward hepatitis C data, that you consider whether it's relevant to the population you're looking at, because I can tell you that most of the data we have on hepatitis C does not relate to the kinds of people you're going to be thinking about in this particular presentation. And that's these people. And the problem is, when we don't have data on these people, we don't have data on how to impact the epidemic, right? Because this is a spawning ground for new cases of hepatitis C. Places where there are drug users with lack of access to clean injection equipment, to good hygiene and all of that. And yet we, consider ourselves to have plans toward global eradication. And the other problem with drug users is that we put them in a category. We're like, okay, we have these people, we have those people, we have people who use drugs. But it's not a monomorphic population. It's not like a clonal group. We have drug users that use opiates, and we have a very different group of drug users that use stimulants. We have some that have been in treatment, some that are in treatment, some that have never been in treatment, and they can behave very, very differently. There's a spectrum of mental illness, from none to, floridly psychotic. And we also have a functional spectrum. We have people, I have a functioning trial lawyer who is an active heroin user, all the way down to the street people who can, barely find their next meal. So we can't really lump all people together who are using drugs into a single category and use that to try to understand how to impact upon the epidemic. But we do know one thing, and that is that people who use drugs are hard to treat. And the other thing we know is that they still need to be treated if we want to impact this epidemic. Here's the good news. Having done this for 20 years, I can not believe my good fortune every day, because now treating hepatitis C is very easy. It's easier as a primary care kind of doctor. It's easier to treat than diabetes and high blood pressure, than HIV and all these other things that we're constantly trying to treat. And, we don't say, well, it's really hard to treat your high blood pressure, so I'm not going to do it. But because these are people who use drugs, we sometimes have that perspective on hepatitis C. It's hard, so I'm not going to do it. What we need to do is just say, okay, it's going to be hard, but we're going to do our best. And that's what we do with these other conditions. And so when you're a radical left-wing pinko that treats addicts, you come across maps like this, which this is a map of the legal needle exchange programs in the United States. This is a few years out of date. And you can see that the needle exchange programs that are mapped are, generally speaking, on the coastal areas and in the states that voted for Hillary. And when you superimpose that map with a map of where I work, you can see that working at needle exchange programs actually makes a lot of sense for somebody like me. However, let's recognize that work like this, which seems like it would have a major impact on the epidemic, would do nothing in large swaths of the middle of our country. So this is just one approach to a very difficult population that may have an impact on hepatitis C in certain areas. This is a more magnified map of where I work. Let's see if I can get this mouse to work. This is where Oakland is, right here across the bay from San Francisco. And this is where I live up here and grow wine grapes, which is a great profession for somebody who does addiction. And I'm going to show you data from two needle exchange programs which are very different. One is in Berkeley, which is adjacent to Oakland, California, and one is up in rural Ukiah, California. It's actually the county seat. There's about 15,000 people there. And I chose these two not just because of proximity, but because they represent very different aspects of needle exchange programs. The urban one, which I'll just continue to call urban instead of Berkeley, is a needle distribution site. People go there, a lot of the people go there are secondary exchangers. They go there to get their needles and syringes and cottons, cookers, rinse water, and leave. They have minimal on-site services, and for folks who have hepatitis C, there's no on-site testing. They do provide referrals to many agencies which are nearby because it's in an urban area. On the other hand, the rural needle exchange program is very different. It's a non-governmental organization. It's been in existence for about almost 30 years now. They do almost daily needle exchange programs if they can staff it, and they have a very high community profile amongst people on the streets, and they offer a lot of other services like psychosocial support, referrals for mental health and medical issues and housing and that sort of thing, and they do on-site fingerstick HIV and hepatitis C testing, and they've been doing that for years. So as we look at these two different kinds of sites, we want to be able to try to answer certain questions. If we go to places like this to offer on-site treatment, which I was prepared to do for 2 to 3 hours a week, every week. Will drug users actually engage in hepatitis C treatment needle exchange programs? Remember, they're going there for injecting equipment, not for hepatitis C. Are they interested even? Can, once we screen them, will they stay? You know, will they come back for hepatitis C treatment? Will they adhere to treatment if we start it? If they start treatment, will they be cured? Will there be problems with reinfection and resistance? And even more importantly, I think, is what level of service provision do we need for this high-risk, high-maintenance population to make treatment possible and successful? And the reason we have to, you know, what we have to keep in mind is that when people show up in needle exchange programs, hepatitis C is not their priority. So when we go to these sites, we think, wow, this is hepatitis C, we're gonna cure, we're gonna shut down this epidemic, but they are not in that mind. They may show up for a hepatitis C intervention, but it's usually an afterthought. So in that particular situation, we want to try to make it as simple as possible and as fast as possible to improve engagement. Unfortunately, that's not easy. And what we've been able to do in terms of simplifying the process is the following. People will show up for an initial screening visit. We don't have access to point of care screening, unfortunately, so we have to do phlebotomy viral testing. The results of that take approximately a week to come back, so they have to return in a week to get the results. And then we get the thumbs up, they want to be treated. It takes us about 2 weeks to get the medications authorized. And then they have to show up again to pick up their hepatitis C medications. The insurance companies will only authorize 2 weeks at a time. So they have to show up at least every 2 weeks to pick up another supply of medications. Sometimes we ask them to do it more if they're unstable, because it's hard to keep track of medications when you're living in homeless encampments. They're stolen, they're lost, etc. Insurers require intervening labs. I don't know why. It really doesn't, you know, provide any additional information. They're either aviremic or almost aviremic. And then probably the hardest thing of all of this is trying to track them down 12 weeks after the treatment's over. And as you look at this data, I just want to point out that there's things that we do that you might not be able to do. Persons who use needles at our site in California qualify for Hep C treatment. We are very, very fortunate in that. It is a public health approach to hepatitis C in the state of California to offer treatment to people who use needles. So that is a criteria. You put it on the prior authorization form, and the medications are approved eventually. We draw blood right on site. I think that's really important, because sending people to a lab when they have no veins doesn't go over very well, and there would be a significant drop-off if we had to do that. And as an addiction specialist, I can also consider to offer heroin users buprenorphine, which certainly can help with retention. So what happened? I pulled out data for a one-year period of time from September 2016 to 2017, and I'll continue to divide this amongst the urban needle exchange in Berkeley and the rural one up in Mendocino County. We did viral testing on over 100 people over a one-year period of time. The majority were male. The median age was older than I had hoped for. It was in the mid-40s overall, a little older in the Mendocino County group, the rural group. It wasn't as diverse as I had hoped for. The majority by far were Caucasian. And a relatively low number were spontaneous remitters, and I attribute that to the fact that we were treating hepatitis C became known, and we became a referral base for some of the local doctors who didn't want to do it themselves. Go figure. This is what we saw in terms of treatment initiation. There were 96 people that were eligible for treatment based on being viremic, as you can see. And about a little over half of those overall in the two sites started treatment. You can see there is a difference in the urban versus the rural site, which I found very interesting. The rural site at the rural site, about 2/3 of the eligible people did start hepatitis C treatment. It was far lower proportionally in the urban group, and I believe that's probably due to the fact that there are a lot more social services available at the rural site. This was their case managers and housing and all of this, and I really think that that probably made all the difference. This is what drug use looked like in the week prior to treatment initiation. Almost a quarter hadn't used any drugs or alcohol at all in the week prior. This is all by self-report. I think the numbers might go down a little if we actually did drug testing. About 43% were using heroin. The majority we were using methamphetamine. You see this adds up to more than 100% because some were using both, and a minority were using alcohol, 8%. So it was a pretty unstable population. Treatment completion was pretty good. We had dropout rates of about 15% overall, and it didn't seem to matter whether they were in a site that had ancillary services or not. We had 8 of 9 in the urban place completed treatment, and 37 of the 45 in the rural site completed. Our criteria for that was with an every 2-week pickup. This is whether they picked up all of their 6 boxes of medications. This is what we saw in terms of adherence. Let me explain what you're looking at. We divided it into three groups. The people who had 90% plus adherence in terms of number of medication doses by self-report that were received or that never were taken away. We had 75 to 89% adherence, and then we had the lower group, 50 to 74%. You can see that despite being a fairly unstable population, 3/4 of them adhered very well. There was an intermediate group, a reasonable, sizable intermediate group of 18, and then a small group of 8 that had lower adherence rates. So then this begs a question as to, how is that going to impact upon outcomes? Because, we come from the world of 80, right? 80% of your interferon, 80% of your ribavirin, at least 80% of the time is your maximum outcome. But we don't have that number in hepatitis C. We don't know what we need. This is what intervening drug and alcohol use did to adherence. So let me take you through this because it's kind of hard to understand this. We looked at people who were drinking, sorry, I'm having trouble with this mouse, drinking alcohol, using heroin, using cocaine, methamphetamine, and smoking marijuana. What happened to adherence in the people who didn't drink alcohol versus those who did? What percent of those were in the highest adherence category? You can see that in all of them, the substance use reduced adherence rates somewhat, except in my favorite drug of abuse, I'm sorry about this mouse, methamphetamine. Methamphetamine is an extremely difficult substance to deal with. The heroin we have treatment for, it calms people down. Methamphetamine users get extraordinarily chaotic, and this is reflected in their inability to adhere at the highest rates. And we saw this uniformly. People who were using methamphetamine, none of them had the highest adherence rates at all. Question is, how does that impact upon treatment outcomes? And so far, of the 54, we only have about 27 of our final SVRs. But what we found that every single one of the patients who completed treatment had an SVR. There was one who disappeared after 1 week we've tracked down who did not have an SVR. But despite the reduced adherence rates, all of them have had SVRs so far. And so our takeaway message so far from this is that you can treat highly unstable patients at needle exchange programs. I would just caution that we do have the co-located venipuncture services and, additionally some buprenorphine, and that may have improved our outcomes, and that needs to be considered. The main weakness we saw, we've looked at this treatment cascade, and the main weakness have seen in our needle exchange work is the drop-off between initial engagement and treatment initiation. And that would make us consider perhaps the next, if we had, if any of this could ever get granted, nobody is interested in this work in the United States. It would be helpful to devote resources to somebody, a peer probably, who would help these folks come back and start hepatitis C treatment. But I think the most kind of exciting thing about this is that these new regimens, the new DAA regimens that are highly potent, really seem to buffer against reduced adherence rates and make it possible to treat people who might not have perfect adherence and offer them sustained virologic response, and thereby not only improving their own health but reducing their potential to pass it on to other people. So where are we heading? Some of the work we're doing now is, I think one of the weaknesses of going to a needle exchange and treating is that they're going home and they have groups they're sharing needles with, potentially, and the potential for reinfection introduces itself. And so we've begun doing some work, network-based treatment by initial engagement needle exchange and going to homes and encampments to try to engage more people in their using group to try to cure all of them at the same time. We've been trying to get them to bring their network in, but that doesn't work, so we're going to go to the network ourselves, which, is interesting. Let's just stop there. And offering small incentives, we know incentives help, improve vaccination rates for hepatitis B, et cetera, et cetera. So we would imagine that even a small $5 subway card might improve engagement in coming to get medications, but we don't know for sure. And then the most controversial thing, which I was not prepared to talk about, but we discussed yesterday, immediate treatment based on point of care versus our the current model of delayed treatment. And the reason this is controversial is that we have to do it different. We don't have point of care testing. And so we've begun, based on having acquired a small stockpile of medications from people who had discontinued treatment early, we now have begun immediate treatment of antibody-positive people not knowing whether they have viremia or not. It takes us 3 to 5 days to find out if they're viremic, but they come in scared to death about their hepatitis C. We draw their blood and we start treatment. There are some people in that group, you saw it's about 15%, who are not viremic, and we reach them in 3 to 5 days and ask them to stop the medication. So we're over-treating using the extra medications we have to see if immediate engagement can improve people's treatment outcomes. I'm skeptical because I think the downside of that, when you introduce immediate treatment, it begins to devalue the medications, which are extremely expensive. But I don't think we really know what the best approach is in this patient population. So that's probably, I probably would have to kill any of you who went out and talked about that outside of this room, because I'm not sure about the ethics of that. But, I think that as we approach, ideas toward eradication, these are the kinds of ideas that we need to implement just because we have very little data to understand how to do it best. Thanks.